Well, let's discuss the key term, female sexual dysfunctions. Sexual dysfunctions are disorders in desire, arousal, and orgasm. Sexual disorders described in the DSM-5 that are found specifically in women include female orgasmic disorder, female sexual interest arousal disorder, and genitopelvic penetration disorder. The first two disorders are characterized by persistent disturbances in the normal sexual response cycle. Women with female sexual interest arousal disorder demonstrate an absence or reduced interest in sexual activity, or an ongoing inability to attain or maintain an adequate lubrication swelling response during sexual excitement. Women with female orgasmic disorder are able to achieve a normal level of sexual excitement, but do not experience orgasm, experience delayed orgasm after the sexual excitement phase, or have orgasms infrequently or of reduced intensity. These disorders are diagnosed when the symptoms cause significant distress or interpersonal disturbance and are not solely due to the effects of a drug or another medical condition. Genitopelvic pain penetration disorder involves there being recurrent and persistent involuntary spasms in the outer third of the vagina that interfere with intercourse. These vaginal spasms occur when penetration with a tampon, speculum, finger, or penis is attempted. In some women, anticipation of penetration is enough to induce muscle spasms. The involuntary vaginal contractions may be experienced as a tightening with mild discomfort or as a ripping, burning, or tearing pain that prevents penetration entirely. Genitopelvic pain penetration disorder is often associated with fearfulness or anxiety regarding intercourse. The condition may be exacerbated by vaginal scarring due to childbearing, surgery, or abuse, irritation from some use of douches, spermicide, or condoms, and from infection. Specifiers indicate whether the condition is lifelong or acquired, and whether the severity is mild, moderate, or severe. Genitopelvic pain penetration disorder is new in the DSM-5 and represents a merging of the DSM-4 categories of vaginismus and dyspareunia, which were highly comorbid and difficult to distinguish. The diagnosis of sexual aversion disorder has been removed due to rare use and lack of supporting research. Sexual dysfunctions are usually caused by performance anxiety, unrealistic expectations, misinformation, early conditioning, and/or ignorance of sexual physiology. Sexual dysfunctions in both men and women are divided into subtypes on the basis of onset, context, and etiology. Sexual dysfunctions that have been present since the onset of sexual functioning are classified as lifelong, while those that appear after a period of normal functioning are classified as acquired type. Sexual dysfunctions that appear in a variety of contexts are classified as generalized type, whereas those that are limited to specific forms of stimulation, situations, or partners are classified as situational type. Treatment approaches employ a variety of methods, including relationship counseling, cognitive restructuring, and sensate focus. Women with female orgasmic disorder may receive instruction in and be encouraged to engage in masturbation. Vaginismus is often treated with relaxation exercises and the gradual dilation of the vagina. Women with sexual dysfunctions may also improve their sexual functioning and enhance sexual pleasure through the use of Kegel exercises, which involves repeated and voluntary tightening of the pelvic floor muscles. Well, let's practice with a question for female sexual arousal disorder. In female sexual arousal disorder compared to orgasmic disorder, the primary problem relates to all of the following except answer choice A, lubrication, B, swelling, C, climax, or D, vasocongestion. Answer C is correct, as lubrication, swelling of external genitalia, and vasocongestion of the pelvic region are all associated with arousal disorder, whereas the orgasmic climax is a primary problem for orgasmic disorder.